Hi, and welcome back to the Pro-PA Podcast. I'm Angie Urbina, your host for this cardiovascular series. Today we're tackling two valvular disorders, tricuspid stenosis and tricuspid regurgitation. While these conditions aren't as commonly discussed as aortic or mitral valve diseases, they are important to recognize and can have significant clinical implications. In this episode, we'll cover the basics from pathophysiology and clinical presentation to diagnosis, management, and prevention. Whether you're preparing for the PANCE, seeing patients in clinic, or just looking to strengthen your cardiology knowledge, this episode has you covered. Let's dive in. Now, we'll start off by talking about tricuspid stenosis, and then we'll talk about tricuspid regurgitation secondly. Tricuspid stenosis is a narrowing of the tricuspid valve which obstructs blood flow from the right atrium to the right ventricle during diastole. The most common cause worldwide is rheumatic heart disease, but in developed countries it is much less common due to the decline of rheumatic fever. Other causes include carcinoid syndrome and congenital heart disease. The narrowing leads to right atrial enlargement, systemic venous congestion, and eventually right heart failure. Who does tricuspid stenosis affect? It is rare in the United States with less than 1% of the population, but is still seen in patients with a history of rheumatic fever, especially in developing countries, and it's more common in women. The symptoms that patients usually experience are mild or no dyspnea, peripheral edema, and fatigue due to reduced cardiac output. On physical exam, you may see evidence of right-sided heart failure, such as jugular venous distension, hepatomegaly, ascites, and peripheral edema. On cardiac auscultation, you want to listen for a mid-diastolic murmur, best heard at the left lower sternal border. This is accentuated with inspiration, which is called Carvalho's sign, and is also accentuated with leg raise, squatting, and exercise. The gold standard for diagnosing tricuspid stenosis is an echocardiogram. It will show thickening of the valve, restricted leaflet motion, reduced valve area, and an increased transvalvular pressure gradient. The management includes salt and fluid restriction and diuretics for systemic venous congestion, treatment of underlying causes such as endocarditis or cardiac tumors, and for symptomatic patients with severe tricuspid stenosis, intervention with surgical valve repair or replacement, or percutaneous balloon valvotomy are indicated. Now, as far as prevention, since tricuspid stenosis is commonly due to rheumatic heart disease, prevention revolves around early detection and treatment of strep infections with antibiotics. Now let's talk about tricuspid regurgitation. It is more common and occurs when the tricuspid valve does not close properly, allowing blood to flow backward into the right atrium during systole. Tricuspid regurgitation can be classified as primary due to valve abnormalities such as infective endocarditis, congenital defects like Epstein anomaly, or carcinoid heart disease, or secondary, which are often due to right atrial and ventricular dilation that secondarily dilates the tricuspid annulus from left-sided heart failure, pulmonary hypertension, or atrial fibrillation. Although tricuspid regurgitation is more common, it often goes undiagnosed. A small degree of regurgitation is found in up to 80% of normal individuals on echocardiography. Additionally, it is important to note that infective endocarditis affecting the tricuspid valve is commonly associated with IV drug use. As far as clinical presentation, tricuspid regurgitation is usually asymptomatic when mild or moderate. However, in severe tricuspid regurgitation, it is associated with symptoms of right heart failure, including dyspnea on exertion, orthopnea, paroxysmal nocturnal dyspnea, abdominal distension, fatigue, and peripheral edema. On physical exam, there may be signs of the right heart failure, such as jugular venous distension, hepatomegaly, ascites, peripheral edema, and hepatojugular reflux. And on cardiac auscultation, you will hear a blowing holosystolic murmur, best heard at the left lower sternal border, which increases with inspiration. which is Carvalho's sign. The intensity decreases with standing or during Valsalva. The diagnosis can also be made through echocardiography, which is the gold standard. Key findings include dilation of the tricuspid annulus, right ventricle and right atrial dilation, and retrograde blood flow from the right ventricle into the right atrium. Management includes systemic volume overload treatment with sodium and fluid restriction and diuretics, treatment of underlying causes such as left heart failure and pulmonary hypertension, and in cases of severe symptomatic tricuspid regurgitation, tricuspid valve intervention is considered. Options include surgical repair or replacement, or transcatheter repair or replacement. Regarding prevention, for tricuspid regurgitation, preventing right ventricular dilation by managing conditions like pulmonary hypertension, atrial fibrillation, and heart failure is key. All right, here are some clinical pearls. Number 1, tricuspid stenosis is most commonly caused by rheumatic heart disease. Number 2, tricuspid regurgitation is often secondary to right ventricular dilation and pulmonary hypertension. Number 3, Carvalho's sign, which is when the murmur increases with inspiration, is a key finding in both tricuspid stenosis and regurgitation. And number 4, diuretics help manage volume overload in both tricuspid stenosis and tricuspid regurgitation, while surgery is reserved for severe cases. All right, let's practice some questions. Question 1. A 56-year-old woman with a history of rheumatic fever presents with progressive fatigue and peripheral edema. On exam, you note jugular venous distension, ascites, hepatomegaly, and a diastolic murmur at the left lower sternal border that increases with inspiration. Which of the following is the most likely diagnosis? Is it A, mitral stenosis, B, tricuspid stenosis, C, pulmonary hypertension, or D, tricuspid regurgitation? I'll give you a couple of seconds. If you chose B, tricuspid stenosis, you are correct. The patient's history of rheumatic fever and diastolic murmur at the left lower sternal border suggests tricuspid stenosis rather than mitral stenosis. The patient's history of rheumatic fever and signs of systemic venous congestion point toward tricuspid stenosis. The murmur's location and enhancement with inspiration further confirm the diagnosis. Question 2. A 72-year-old man presents with mild dyspnea on exertion and lower extremity edema. Patient takes medications for COPD, hypertension, and hyperlipidemia. Physical exam reveals hepatomegaly, peripheral edema, and a holosystolic murmur at the left lower sternal border that increases with inspiration. Transthoracic echocardiography confirms tricuspid regurgitation. Which of the following is the next best step in management? Is it A, prescribe beta blockers and monitor, B, initiate diuretics and treat underlying cause, C, refer for emergent valve replacement, or D, begin long-term anticoagulation? If you chose B, initiate diuretics and treat underlying cause, you are correct. Initial management of tricuspid regurgitation focuses on fluid overload reduction with diuretics, while also addressing any underlying conditions like left-sided heart failure or pulmonary hypertension. Great job! That wraps up our discussion on tricuspid stenosis and tricuspid regurgitation. While these conditions may not be as common as aortic or mitral valve disease, recognizing their signs and knowing when to intervene is essential. Be sure to subscribe for more cardiology topics. And as always, this is the Pro-PA Podcast, where future pros in medicine are made. See you next time.